All right, let's dive in. Today, we're going to revisit a familiar foe for all you medical microbiologists out there, community-acquired pneumonia, or, as we all know it, CAP.
Ah, CAP. Classic.
But we're zeroing in on the milder CAP cases, the ones you typically see in primary care. And to guide us, we have the World Health Organization's AWARE publication, Chapter 12 to be exact.
Always a good place to start.
It is. Think of this deep dive as a little refresher course, hitting the high points of diagnosis and treatment for mild CAP.
Sounds good to me.
Perfect. So first things first, how does the WHO actually define CAP? What makes it stand out from, all the other respiratory illnesses out there?
Well, they define it as an acute infection, primarily hitting the lungs. Usually the culprits are those familiar pathogens, bacteria, or viruses.
So like the usual suspect.
Exactly. But the key here is that CAP is all about the lungs. It shows up with specific symptoms like cough, fever, and difficulty breathing.
That helps separate it from, say, just a plain old upper respiratory tract infection.
Right. It's not just a bad cold. It's more than that.
But those symptoms can be tricky sometimes, can't they? Like, how can we really be sure it's bacterial CAP and not viral or something else, just based on what we see in the patient?
It definitely can be a challenge. That's where a good grasp of local epidemiology comes in handy. Knowing what bugs are circulating in your area helps narrow things down, gives you a starting point.
Makes sense. So, for example, if the flu's going around like wildfire.
Exactly. That might change your initial thinking.
Gotcha. So, let's say you suspect CAP. Do we always need to order lab tests, especially for these milder cases managed in primary care?
The good news is, for most of those straightforward CAP cases, you don't need a ton of testing. The WHO guidelines really emphasize that thorough clinical assessment. Let that guide your treatment decisions.
So for those clear-cut cases, we can sometimes skip the lab workup.
Often, yes.
That's reassuring.
Yeah.
But I'm sure there are exceptions. When would we want to order tests?
Oh, absolutely. There are definitely situations where testing is important. For instance, if the patient's symptoms are pointing towards influenza or even COVID-19.
Can't forget about those.
Right. Especially if they're circulating in the community. Then testing for those viruses would be a good idea.
Makes sense. Anything else to keep in mind?
Another critical point is ruling out tuberculosis, especially in areas where TB is endemic, and especially in patients who are at higher risk.
So we need to be extra careful there.
Definitely. The WHO really pushes for using those rapid molecular tests to rule out TB.
Makes sense. Rule out the big players, but otherwise, clinical judgment is king.
For these milder cases, yeah.
All right. Now, let's talk about the cases where we do need to get into the nitty-gritty of microbiology. When do those tests become necessary?
Microbiology tests are most helpful when we need to really pinpoint which antibiotic to use, particularly in more severe cases.
So we're trying to identify the exact culprit.
Exactly. Blood cultures are usually our go-to, and urinary antigens can be useful for picking up specific pathogens.
Like what?
Legionella pneumophila and Streptococcus pneumonia are good examples.
Those are some familiar names.
They are. But it's worth remembering that even with a bunch of tests, pinning down the exact bug can be tough. And honestly, for those mild CIP cases, we usually don't need to go that deep.
All right, so we don't always need the full workup. What about other lab tests? Anything else besides microbiology that can be helpful in diagnosing CIP?
There are a few others that can give us some clues. Things like a full blood count and C-reactive protein can help us figure out if it's more likely bacterial or viral.
More information to work with.
Exactly. But again, the choice of tests really depends on the situation, how sick the patient is, and what tests are actually available.
Makes sense. Okay, last but not least, let's talk about imaging. Chest x-rays. Are those always a must-have for CIP?
Not always. For those straightforward, mild cases you'd see in primary care, they're usually not necessary.
Another potential step we can skip.
Right.
So when are chest x-rays actually helpful?
They become more useful if it's a severe case or if we're just not sure about the diagnosis. And it's important to remember that even if the x-ray looks like pneumonia, it can't tell you exactly what's causing it. It's just one piece of the puzzle.
Got it. Imaging can support our suspicions, but it can't give us the definitive answer.
Exactly.
Okay, let's move on to the main event. Treatment. What's our overarching goal when we're managing mild CKP?
Well, the goal is pretty simple. We want to jump in quickly and effectively and get rid of that infection. And for the most part, that means targeting Streptococcus pneumonia. That's the most common bacterial cause of CAP.
Strep pneumo, the usual suspect. So let's get specific about those antibiotics. What are the WHO's current recommendations for treating mild to moderate CAP in adults?
For first-line treatment, they recommend oral penicillin.
Good old penicillin.
Yep, still going strong. They recommend either amoxicillin, 1 gram every 8 hours, or phenoxymethylpenicillin, 500 milligrams every 6 hours.
All right, so penicillin is our first choice. But what if we run into resistance, or those aren't suitable options for some reason? What are our alternatives?
In those cases, the WHO recommends either amoxicillin clagulanic acid, that's 875 milligrams plus 125 milligrams every 8 hours, or doxycycline at 100 milligrams every 12 hours.
Okay, so we have our first line and our backup choices. Now, how long do we typically keep patients on these antibiotics? What's the usual treatment duration?
The general recommendation is 5 days for most adults.
Okay, 5 days. But I'm guessing that's not set in stone.
Right. You always want to adjust the treatment duration based on how the patient is doing, how they're improving.
Always individualize. Now, I'd love to zoom in a bit on the pathophysiology of CAP. What's actually going on in the body when someone develops this infection?
It's actually pretty fascinating. Those pathogens, whether they're bacteria or viruses, they manage to get into the lower respiratory tract, specifically the alveolar.
Little air sacs in the lungs, right?
That's right. And once they're in there, they start to multiply, which triggers the body's immune response.
And that's what causes all the problems.
Right. That leads to inflammation and damage to the lung tissue, and that's what causes all those classic pneumonia symptoms.
So it's a battle between the invaders and the body's defenses.
Exactly. And when those defenses get overwhelmed, that's when we see the full-blown infection.
Okay, that makes sense. Now, I want to switch gears a bit and talk about the global impact of CAP. How common is this infection around the world?
It's more common than you might think. In 2017 alone, the WHO estimated a whopping 471 million new cases of lower respiratory tract infections globally, and CAP makes up a significant chunk of those.
Wow, that's a lot of cases. Are there any specific regions or populations that are hit harder by CAP than others?
Unfortunately, yes. Low-income countries bear a much larger burden, and children under 5 are particularly vulnerable.
Why is that?
Well, there are a lot of factors at play. Things like malnutrition, HIV infection, exposure to smoke, and even air pollution. All of those can make CAP much more severe in young children.
That's really concerning. Have we made any progress in fighting CAP globally?
There is some good news. Global mortality rates have actually gone down.
That's encouraging.
It is, and that's largely thanks to better healthcare and vaccination efforts. But even with that progress, CAP is still a major global health challenge. There's definitely more work to be done.
Absolutely. Okay, before we wrap up this part of our deep dive, I'm curious about the pathogens themselves. Who are the usual suspects behind CAP, and does it vary by age group?
It absolutely does. For newborns and babies up to 2 months old, the most common culprits are Streptococcus pneumonia, Group B strep, Enterobacterales, or Staphylococcus aureus.
So right from the start, we see those heavy hitters.
Right. Now, when we look at children from 2 months to 5 years old, viruses start to take the lead.
Like what kind of viruses?
Respiratory syncytial virus, or RSV, is a big one. Then you have influenza and parainfluenza virus. But even in this age group, Streptococcus pneumonia is still a major bacterial threat.
So strep pneumo is a problem across the board. What about older children and adults?
In older kids, strep pneumo is still common, but we also start to see more of those atypical bacteria like Mycoplasma pneumonia and Chlamydia pneumonia.
Okay, and what about adults?
For adults, the usual suspects include viruses, Streptococcus pneumonia, those atypical bacteria again, plus Haemophilus influenza, Moraxella catarrhalis, and Staphylococcus aureus.
So quite a mix depending on the age group.
Exactly. And it's worth mentioning that sometimes you get more than one pathogen at play. Mixed infections aren't that unusual.
That definitely complicates things.
It does. And even with all the tests we have, pinning down the exact cause isn't always easy, especially in those milder cases.
Right. And we can't forget about geography either.
Oh, absolutely. We always have to think about regional pathogens. Like in Southeast Asia, Burkholderia pseudomallei is a significant cause of CAP. And in areas with a lot of livestock, Coxiella burnetii is more common.
So many factors to consider. Okay, I think we've covered a lot of ground in this first part of our deep dive. We've talked about the definition of CAP, those tricky clinical presentations, when to order lab tests and imaging, and those ever-important pathogens.
It's been a good review of the basics.
Now, I think it's time to put your knowledge to the test. Are you ready for a little pop quiz? A few quick exam-style questions to see what you've learned.
I'm game. Hit me with your best shot.
All right, first question. A 35-year-old patient walks in with fever, cough, and shortness of breath. Their CRB65 score is 1, and they have no other health problems. Based on the WHO guidelines, which of the following would be the most appropriate initial antibiotic? A. Intravenous ceftriaxone, B. Oral amoxicillin, C. Intravenous vancomycin, or D. Oral azithromycin.
Well, their CRB65 is pretty low, and they don't have any comorbidities. Seems like a pretty mild case, probably good for outpatient management, so I'd go with B. Oral amoxicillin.
You nailed it. The WHO recommends oral amoxicillin, or phenoxymethylpenicillin, as the first-line treatment for mild CAP in adults. Intravenous ceftriaxone would be more for severe cases, and vancomycin and azithromycin wouldn't be our first choices in this scenario.
Makes sense. Got to pick the right tool for the job.
Exactly. Okay, ready for question number 2.
Bring it on.
All right. Which of these lab tests is most helpful for figuring out if a pneumonia is bacterial or viral? A. Procalcitonin. B. Lactate dehydrogenase, LDH. C. C-reactive protein, CRP. Or D. White blood cell, WBC count.
Okay, so all of these can tell us something about inflammation, but I think the most helpful one for distinguishing between bacterial and viral pneumonia is C-reactive protein.
Yeah.
If the CRP is high, it points more towards a bacterial cause.
Spot on. CRP is a really sensitive marker for inflammation.
It's not perfect, of course, but it's a good piece of information to have.
Absolutely. All right, question number 3. A 5-year-old comes in with fever, cough, and wheezing. Which of these pathogens is the most likely culprit for their pneumonia? A. Streptococcus pneumonia, B. Mycoplasma pneumonia, C. Respiratory syncytial virus, RSV, or D. Legionella pneumophila.
A 5-year-old with wheezing, I'd say the most likely cause is CRSV. It's really common in young kids, especially this time of year.
You got it. While Streptococcus pneumonia can cause pneumonia in any age group, RSV is much more likely in this case, especially with the wheezing.
Age is a big clue when it comes to pneumonia.
It really is. All right, question number 4. We have a 70-year-old patient with a history of heart failure who's hospitalized with severe CAP. Their CRB65 score is 3. What's the most appropriate way to manage this patient? A. Outpatient treatment with oral amoxicillin. B. Hospitalization and intravenous ceftriaxone. C. Outpatient treatment with oral azithromycin. Or D. Observation in the emergency department for 24 hours.
Okay, so this patient has a few red flags. They're older, have heart failure, and their CRB65 is 3. That tells me this is severe CAP. So I'd go with B, hospitalization and intravenous ceftriaxone.
You're absolutely right. Severe CAP needs a more aggressive approach.
We need to hit it hard and fast.
Exactly. Okay, last question. What's a key principle of antibiotic stewardship when it comes to managing CAPA? Prescribing antibiotics for all cases of suspected pneumonia, regardless of the cause. B. Encouraging patients to stop taking antibiotics once they feel better, even if they haven't finished the full course. C. Making sure the antibiotic covers the most likely pathogens, using narrow-spectrum antibiotics whenever possible. Or D. Using broad-spectrum antibiotics as the first-line treatment for all pneumonia cases to make sure we've got it covered.
Oh, this is an important one. I'd say the key principle is C. Making sure the antibiotic covers the most likely pathogens, using narrow-spectrum antibiotics whenever possible.
You are absolutely correct. Antibiotic stewardship is all about using antibiotics wisely. That means choosing the right antibiotic, using the narrowest spectrum we can, and avoiding unnecessary or prolonged treatment.
We need to protect those antibiotics, make sure they keep working.
Exactly. All right, I think we've reached a good stopping point for this part of our deep dive into community-acquired pneumonia. We've covered a lot, from basic definitions and clinical presentations to the ins and outs of antibiotic treatment and the importance of antibiotic stewardship.
It's been a good refresher.
It has. Now be sure to join us again for part 2. We'll be tackling severe CAP in more depth and diving into the ever-evolving landscape of antibiotic resistance. Until then, keep those brains sharp and stay curious.
See you next time. Welcome back to our deep dive on community-acquired pneumonia.
In part 1, we covered those milder CAP cases, the ones you can usually handle in primary care.
Right, the more straightforward ones.
But now, we're going to step things up. We're shifting gears to severe CAP.
The cases that land patients in the hospital.
Exactly. And we're sticking with our trusty guide, the World Health Organization's AWARE publication, Chapter 12.
Always a good source of information.
It is. So, let's set the scene. What should make us think, uh-oh, this is getting serious. This isn't just a mild case anymore.
Well, the WHO outlines a bunch of clinical signs that should raise red flags.
Like what? What are we looking for?
Things like a really fast breathing rate, struggling to breathe, low oxygen levels.
Those sound pretty serious.
They are. And also, if the patient is confused or their mental status is off, that's a big concern.
So we're looking for signs that the infection is impacting their breathing and their brain.
Exactly. Those are signs that the patient might need to be hospitalized.
Okay, so we see those red flags. How do we actually assess the severity of their CAP?
There are a few tools we can use.
Any particular one you like?
The CURB-65 score is a popular one.
Ah, CURB-65. Good old C or B-65.
It takes into account a bunch of factors.
Like what? Remind me.
Confusion, high blood urea nitrogen, a fast breathing rate, low blood pressure, and if they're 65 or older.
So it looks at their labs, their vitals, and their age.
Yep. It's a pretty comprehensive assessment.
And how do we use that score? What does it tell us?
Well, the score goes from 0 to 5. The higher the score, the sicker the patient, and the higher the risk of complications.
So a low score is good, a high score is bad.
Basically, yeah. If the score is 0 or 1, that's low risk, and they might be okay to manage at home.
But if it's higher?
If it's 2 or higher, we really need to think about admitting them to the hospital. And if it's 3 or more, that's high risk, and they might even need the ICU.
So C or B65 helps us figure out who needs to be hospitalized and who might be okay at home.
Exactly. It helps us stratify patients based on their risk.
But it's important to remember it's just a tool, right? It's not the be-all and end-all.
Right. We always have to use our clinical judgment, look at the whole picture.
Absolutely. Okay, let's talk about the bugs themselves. Are there any differences in the likely pathogens for severe CIP compared to mild CIP?
You know, we often see the same usual suspects.
Like strep pneumo?
Yep, strep pneumo is still a common one. But in severe CPAP, we might see more of those really aggressive bacteria.
Like what?
Things like Staphylococcus aureus, especially MRSA, and also gram-negative organisms.
Those are the tougher ones to treat.
They can be.
So we're dealing with a different level of threat here. How does that affect our choice of antibiotics?
Well, with severe CIP, we need to use broad-spectrum antibiotics.
To cover all our bases.
Right. We need to hit a wider range of potential pathogens because some of them might be resistant to the usual antibiotics.
We're casting a wider net to make sure we catch the culprit. So what specific antibiotics does the WHO recommend for severe CAP?
They recommend starting with intravenous antibiotics.
Okay, IV antibiotics. What are our options?
The go-to choices are cefotaxime, 2 grams every 8 hours, or ceftriaxone, 2 grams every 24 hours.
Those are some strong antibiotics.
They are. They're both third-generation cephalosporins, and they have good activity against a lot of different bacteria.
So they cover a lot of ground.
Exactly.
Now, what if we suspect an atypical bacterial infection? Do we change our approach?
If the CURB-65 score is 2 or higher, or if we're really suspicious of those atypical pathogens like Legionella or Mycoplasma, the WHO recommends adding clarithromycin to the mix.
Clarithromycin. That's a macrolide, right?
Yep. It's good for covering those atypical bacteria.
So we're adding another layer of coverage.
Right. But sometimes those first-line options just aren't appropriate. Or we might be dealing with resistance.
What do we do then?
In those cases, the WHO recommends amoxicillin clavulanic acid, 1 gram plus 200 milligrams every 8 hours, given intravenously.
That's a powerful combination.
It is. It gives us broader coverage, especially against those bacteria that produce beta-lactamyces.
The ones that can break down certain antibiotics.
Exactly.
So we always need to have a backup plan, especially with severe CAP.
Absolutely. Now, there's one specific pathogen that we need to talk about in the context of CAP.
Which one?
Mycobacterium tuberculosis.
Ah, TB. Can't forget about TB.
Right. TB can affect the lungs and mimic pneumonia, so we always need to consider it, especially in areas where TB is common.
Or if the patient has risk factors for TB.
Exactly. Things like HIV infection or close contact with someone who has TB.
So how do we rule out TB in these patients?
The WHO recommends using those rapid molecular tests like the GeneXpert.
Those are pretty quick and accurate, right?
They are. They can tell us if the patient has TB and if it's resistant to rifampicin.
So we can get the right treatment started right away.
Exactly. But sometimes those initial tests aren't clear-cut.
What do we do then?
We need to keep investigating. Maybe do more sputum tests, as a chest x-ray, or other tests. Sometimes we have to wait for cultures to grow, and that can take a few weeks.
So it might take some time to get a definitive answer.
It might, but we can't give up. We need to make sure we're not missing TB.
Okay, let's talk about the overall management of severe CIP. We've talked about antibiotics, but what else is important?
Besides the antibiotics, supportive care is crucial.
What do you mean by supportive care?
Things like oxygen therapy, giving them fluids through an IV, and sometimes even mechanical ventilation if they're having a really hard time breathing.
So we're supporting their body while the antibiotics do their job.
Right, we're giving their body the best chance to fight off the infection.
Now, what about the length of treatment? Is it the same for severe CKP as it is for mild CKP?
Not always. With severe CAP, we usually treat for longer.
How much longer?
It really depends on the patient, how sick they are, how well they respond to treatment, and if they develop any complications.
Well, so we individualize the treatment plan and watch them closely.
Exactly.
Okay, let's talk about something that's important for both mild and severe CAP. Antibiotic stewardship.
Antibiotic stewardship, a crucial topic.
It is. What exactly is antibiotic stewardship, and why is it so important for pneumonia?
Well, antibiotic stewardship is all about using antibiotics wisely, making sure we're using the right antibiotic at the right dose for the right amount of time, and only when we really need them.
So not just throwing antibiotics at every cough and cold.
Right, because if we overuse antibiotics, they might not work as well when we really need them.
That's the problem with antibiotic resistance.
Exactly, and that's why antibiotic stewardship is so important for pneumonia. We need to make sure we're not contributing to the problem of resistance.
So how do we promote good antibiotic stewardship when we're managing CAP? What can we do in our practice?
Well, first of all, we need to be sure about our diagnosis. Are we really dealing with bacterial pneumonia, or is it viral? Or is it something else entirely?
So don't jump to antibiotics too quickly.
Right. And once we've decided that antibiotics are necessary, we need to pick the right one.
How do we do that?
We need to think about the most likely pathogens and the severity of the infection. We want to use narrow-spectrum antibiotics whenever possible.
To minimize the risk of resistance.
Exactly. And we need to make sure we're using the correct dose and treating for the right length of time. No unnecessarily long courses of antibiotics.
So it's about choosing wisely, using them appropriately, and monitoring the patient's response.
It's a multi-pronged approach.
Now, let's switch gears a bit and talk about prevention. Can we do anything to prevent CAP in the first place?
Vaccination is a big one.
Vaccines for pneumonia.
Yep. There are vaccines for streptococcus pneumonia, Haemophilus influenza type B, and influenza.
And those can help prevent pneumonia.
Absolutely, especially for people who are at higher risk, like young children and older adults.
So vaccination is key. What else can we do?
We need to promote good hand hygiene, tell people to quit smoking, and manage any underlying health conditions that might increase their risk of pneumonia.
Like COPD or heart failure.
Right. It's all about taking a proactive approach to prevention.
Absolutely. Okay, I think we've covered a lot of ground in this segment. We've talked about red flags for severe CAP, those important treatment decisions, antibiotic stewardship, and even prevention.
It's been a pretty comprehensive overview.
It has. Now, are you ready to test your knowledge again? We have 5 more challenging exam questions coming up in the final part of our deep dive.
Bring it on. I'm ready for the challenge.
All right, stay tuned to the grand finale. We'll be back in just a moment. Welcome back to the final round of our community-acquired pneumonia deep dive.
We've covered a lot of ground, from mild cases to the more serious stuff.
We have. And now it's time to put all that knowledge to the test. 5 more exam-style questions coming your way. Ready to see what you've learned?
Always ready for a challenge. Let's do it.
All right. Question number 1. A 40-year-old patient with HIV comes in with fever, cough, and they've lost some weight. The chest X-ray shows some cavitary lesions. Which diagnostic test is the most important to do in this situation? A, sputum culture for bacteria, B, blood culture for fungi, C, sputum smear for acid-fast bacilli, or D, urine antigen test for Legionella?
Okay, so we've got HIV, cough, weight loss, and cavitary lesions on the X-ray. That really makes me think of tuberculosis. So I'd say the most important test here is C, sputum smear for acid-fast bacilli. We need to rule out TB.
You're absolutely right. TB is a serious possibility, especially with those risk factors. Early diagnosis is so important for getting the right treatment started and preventing the spread of TB.
Absolutely. We can't afford to miss TB.
Okay, question number 2. A 28-year-old, totally healthy before this, comes in with fever, chills, and a cough. They're coughing up rust-colored sputum. Which pathogen is most likely causing their pneumonia? A, Mycoplasma pneumonia, B, Chlamydia pneumonia, C, Streptococcus pneumonia, or D, Legionella pneumophila?
Rust-colored sputum, that's a classic sign, isn't it? I'd say C. streptococcus pneumonia is the most likely culprit here.
You nailed it. That's a textbook presentation for strep pneumo. It's one of the most common causes of CKP. And recognizing those key clinical features can really help us make the right diagnosis.
It helps us narrow things down quickly.
Absolutely. All right, question number 3. Which of these statements about using chest x-rays for CAP is the most accurate? A. We need to do a chest x-ray for everyone with suspected CAP, no matter how sick they are. B. Chest x-rays are only for patients who are hospitalized with severe CAP. C. Chest x-rays help us tell the difference between typical and atypical pneumonia. D. Chest x-rays can help confirm the diagnosis of CAP and show us any complications, but we don't always need them for mild cases.
I think the most accurate statement is D. Chest x-rays can be helpful for confirming CAP and seeing if there are any complications, but we don't always need them for mild cases.
That's right. We don't need to order a chest x-ray for every cough and sniffle. For those simple, mild cases, the clinical picture is often enough to make a diagnosis.
We want to be smart about when we use imaging.
Absolutely. Okay, question number 4. A 65-year-old with a history of heart failure is in the hospital with severe CAP. Their blood cultures grow methicillin-resistant Staphylococcus aureus, MRSA. Which antibiotic is the best choice for treating their pneumonia? A. Ceftriaxone, B. amoxicillin, C. vancomycin, or D. azithromycin?
Wow, so we have severe CAP and MRSA. That's a tough combination. We need something strong. I think the best choice here is C. vancomycin. It's active against MRSA, and we can give it intravenously to make sure it gets to where it needs to go.
That's a really important point. We need to know those resistance patterns. Choosing the right antibiotic can make all the difference.
Absolutely. We're always in a battle against resistance.
Okay, last question. What's the recommended length of treatment for most adults with uncomplicated mild CAP? A. 3 days, B. 5 days, C. 7 days, or D. 10 days?
For uncomplicated mild CAP, I think the WHO recommends B. 5 days.
You got it. 5 days is usually enough to knock out the infection without overdoing it on the antibiotics.
Shorter courses of antibiotics are better, fewer side effects, less risk of resistance.
Exactly. Well, I think those 5 questions have really hammered home the key points about CAP. We've covered so much in this deep dive, from diagnosis and treatment to antibiotic stewardship and even prevention.
It's been a great review, a good way to refresh our knowledge.
It has. For those of you listening, I hope you found this deep dive into community-acquired pneumonia informative and, dare I say, even a little bit fun. Keep those brains engaged, keep learning, and keep up the great work in the fascinating world of microbes.
And thanks for joining us.